Welcome to this teaching presentation on juvenile myoclonic epilepsy, or JME. We will begin with a clinical scenario because JME is often recognized or missed through careful bedside reasoning. A generalized tonic-clonic seizure may be the dramatic event that brings the adolescent to medical attention, but the most important diagnostic clue may be something much smaller, a brief morning twitch that the patient never thought was a seizure. Next slide, please. By the end of this presentation, we should be able to recognize the core clinical pattern of JME, use targeted history to uncover previously unrecognized myoclonic seizures, interpret supportive EEG findings in the right clinical context, and choose appropriate treatment and counseling priorities. The goal is not simply to memorize facts, but to integrate the history, timing, triggers, EEG, and management decisions into a coherent clinical approach. Next slide, please. Let us begin with the clinical vignette. A 14-year-old girl is found at 6 a.m. having a generalized tonic-clonic seizure of unknown duration. In the emergency department, she is postictal, but her neurological examination is normal. Her CT scan CBC, electrolytes, and liver function tests are also normal. The patient and her mother initially deny any prior seizures. At first glance, this could appear to be a single isolated seizure, perhaps influenced by stress and poor sleep. But normal tests do not exclude an epilepsy syndrome, and this is where deeper clinical reasoning becomes essential. Next slide. The diagnosis begins to change when we ask a more focused question. Does she ever have brief hand jerks, especially after waking? Does she drop objects in the morning? Are the jerks worse after sleep deprivation? Many adolescents do not volunteer these symptoms because they may describe them as clumsiness, shakiness, or a minor nuisance. In this case, the patient reports occasional early morning hand twitching and tremulousness, especially after poor sleep and emotional stress. That single targeted question shifts the case from first seizure toward a recognizable epilepsy syndrome. Next slide, please. Now we can assemble the diagnostic pattern. The patient is an adolescent. The generalized seizure occurred shortly after waking. Sleep deprivation was present. There is a history of subtle morning myoclonic jerks. Her neurological examination is normal. Taken together, these features strongly suggest juvenile myoclonic epilepsy. The key point is that JME is not diagnosed from one isolated sign. It is diagnosed by recognizing a clinical pattern supported by history, timing, triggers, seizure semiology, and EEG findings. Next slide, please. The EEG provides important support for the clinical diagnosis. In JME, the background is often normal for age, while the epileptiform activity may appear as generalized rapid spike and wave or multiple spike and wave discharges. These discharges may become more frequent during drowsiness and sleep deprivation can improve diagnostic yield. However, the EEG should not be interpreted in isolation. The history gives the EEG its meaning, and a normal EEG does not completely rule out JME when the clinical pattern is strong. Next slide, please. The EEG pattern in juvenile myoclonic epilepsy is classically described as rapid generalized bursts of multiple spikes followed by slow waves, often in the range of about 3.5 to 6 Hz. These discharges may be more prominent frontally and may be activated by sleep deprivation or photic stimulation. For the clinician, the practical message is that this EEG pattern supports an idiopathic generalized epilepsy syndrome, especially when it matches the clinical history of adolescent onset and morning myoclonus. Next slide, please. At this stage, the diagnostic synthesis becomes clear. The generalized tonic-clonic seizure was the presenting event, but it was not the whole story. The earlier morning jerks were already seizures, even if the patient did not recognize them as such. When adolescent onset, awakening-related seizures, sleep deprivation sensitivity, morning myoclonus, and generalized EEG discharges are brought together, the most likely diagnosis is juvenile myoclonic epilepsy. Next slide, please. It is also important to avoid common diagnostic traps. A first isolated generalized seizure may seem plausible because the initial history denies previous seizures. Syncope, or a non-epileptic event, may be considered when the initial tests are normal. Focal epilepsy may be suspected because the generalized convulsion is dramatic. Absence epilepsy may also enter the differential because adolescent generalized epilepsies can overlap clinically. The reasoning correction is to look specifically for unrecognized myoclonus, interpret the postictal state and EEG pattern carefully, and recognize that morning jerks and rapid generalized discharges favored JME. Next slide. Management should treat the syndrome, not only the presenting seizure. Although many patients with a single unprovoked seizure are not immediately started on chronic antiseizure medication, this patient has already had myoclonic seizures before the generalized tonic-clonic seizure. Therefore, treatment is justified. The best next step is to diagnose JME, start an appropriate broad-spectrum antiseizure medication, and provide clear counseling about lifestyle triggers and long-term management. Next slide, please. Treatment planning should combine medication and education. A broad-spectrum antiseizure medication appropriate for generalized epilepsy is needed, and levetiracetam is one suitable option. Clonazepam may help selected patients who have flurries of myoclonic jerks, but medication alone is not enough. Sleep protection is central in JME, because sleep deprivation can provoke both EEG discharges and clinical seizures. Adherence, avoidance of heavy alcohol, follow-up, and family education should be part of the plan from the first visit. Next slide. Patient and family education translates the diagnosis into daily action. The adolescent should know to report morning jerks, dropped objects, or clusters of symptoms. Regular sleep and avoidance of late nights should be emphasized. Medication should be taken consistently and should not be stopped abruptly. Heavy alcohol and other seizure-provoking habits should be avoided. Follow-up should also include school performance, safety, mood, and the psychosocial impact of living with epilepsy. The goal is to give the patient a plan that is medically sound and realistic for daily life. To conclude, the clinical pearl is simple but powerful. Ask about morning jerks in every adolescent who presents with a first generalized tonic-clonic seizure. This one question can uncover juvenile myoclonic epilepsy, change the diagnosis, justify treatment, and guide counseling that reduces future seizure risk. JME is a syndrome-level diagnosis, and recognizing it early can improve seizure control, safety, and long-term outcomes. This presentation was selected from Professor Mohammadi's Educational Archive. Thank you for watching, and I hope this case reinforces the importance of careful, syndrome-directed history taking in adolescents with generalized seizures.